This podcast is being recorded on the lands of the Wurundjeri and the Bunurong people of the Kulin Nation. We pay our respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders, past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we will use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand.
Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest clinical guidelines and research in obstetrics and gynecology through conversation with leading experts. Today we are discussing the early insight from the Safer Baby Bundle in Victoria, Australia's national initiative to reduce the number of stillborn babies by 20%. We'll be looking at the impact this initiative has had on maternity care since its introduction and how to ensure you're implementing it appropriately in your clinical practice. I am Associate Professor Roshan Zeirideen Zaid, and I'm an obstetrician and gynecologist. Joining me today are Dr. Keeth, Mayakaduwage and Dr. Penny Sheehan. Keeth and Penny, would you be kind enough to introduce yourselves and talk us through your experience on this topic?
My name is Dr. Keeth Mayakaduwage. I am a clinician researcher from Monash Health and Monash University in Melbourne, Australia, and I'm the Research and Evaluation Coordinator for the Safer Birthing Centre of Excellence within Monash Health. I am the lead author for the ANZJOG series that we'll be discussing today, looking at the early impacts of the bundle in Victoria, and work across multiple different stillbirth prevention projects with the International Stillbirth Alliance. I also work within a tertiary obstetrics and gynecology service and have clinical experience in providing care for families who've experienced a stillbirth.
And my name's Dr. Penny Sheehan. I'm an obstetrician from the Royal Women's Hospital in Melbourne. And among other things that I've done, for the last 3 years, I've been the clinical lead for the Maternity and Newborn Improvement Team at Safer Care Victoria and have had involvement with the Safer Baby Collaborative and implementation of the Safer Baby Bundle, both at a service level and also at the level of Safer Care.
And before we begin, could you both please declare any relevant conflicts of interest?
I have no conflicts of interest to declare.
I have no conflicts of interest.
And I have none to declare as well. The Safer Baby Bundle was launched in 2019 with the goal of reducing the national late gestation stillbirth rate from 2.4 per 1,000 births to 1.9 per 1,000 births. Let's start by looking at the context of stillbirth in Australia. What are the primary causes of stillbirth in Australia?
So Australia is one of the safest countries in the world for childbirth, but stillbirth remains a significant public health issue and often under-recognised issue as well. In Australia, stillbirth is defined as the birth of a baby without signs of life at 20 or more completed weeks of gestation or weighing at least 400 grams. To put this in perspective, on an average day in Australia, more than 6 babies are stillborn. That's around 4 in the second trimester and 2 in the third trimester. I think it's also helpful to know where stillbirth sits more broadly. So when we talk about perinatal deaths, we're referring to stillbirths and neonatal deaths, which are deaths in the first 28 days after birth. In 2022, there were just under 300,000 births in Australia and just over 3,000 perinatal deaths, so about 1% of babies born. So of these, about 3/4 were stillbirths, so they make up the majority of perinatal mortality. The Australian Institute of Health and Welfare classifies causes of stillbirth using the Perinatal Society of Australia and New Zealand, so PSANZ's perinatal classification system. Congenital anomalies remains the leading overall cause, contributing to about 30% of cases, and these are conditions that affect the baby's structure, chromosomes, or organ development. Maternal medical conditions contributes to about 16%, and this includes terminations of pregnancy for maternal psychosocial indications and a variety of conditions such as gestational or pre-existing diabetes, maternal injury and sepsis and antiphospholipid syndrome. Unexplained stillbirth makes up about 14%, and this means there is no defined cause despite investigation or due to unknown or incomplete investigation. And we see placental dysfunction about 10% of stillbirths and spontaneous preterm birth at around 8%. There are various other causes like infections, hypertensive disorders, antepartum hemorrhage, and specific prenatal conditions, but that's a broad overview of what the causes are.
Penny, coming to you, which population groups are more affected by stillbirth and what are the key modifiable factors that influence this?
We know that the relationship between maternal age and stillbirth risk follows a U-shaped kind of curve, with higher rates at younger ages and also in women aged over 35. And I've got to say the latter group is making up more and more of our maternity population. Women in their first pregnancy have a higher likelihood of stillbirth. The modifiable factors that are associated with increased risk include maternal smoking, maternal BMI greater than 30, a habit of sleeping on your back throughout the whole night. There's a well-documented disparity in stillbirth rates between our First Nations people and other populations within Australia, and a lot of work is being done to try and address this. Rates are approximately 50% higher in our First Nations women, and so that's around 13 compared to 7, say, per 1,000 births. There's a whole complex interplay of factors there contributing to this: access to care, the social determinants of health, as well as systemic inequities. Apart from our First Nations women born in Australia, also maternal country of birth is associated with variation in stillbirth rates. And women born in South Asia and parts of Africa, even in Australia, do experience higher rates.
And Keith, can you talk us through some of the events that led to the development and implementation of Safer Baby Bundle?
So in 2015, Australia's stillbirth rate for babies born at more than 28 weeks was 35% higher than countries with the lowest rates globally. Australia ranked 15th among high-income countries for the annual rate of reduction in stillbirth, which was around 1.4% at the time. And this highlighted a significant gap between the available evidence and the clinical practice, really highlighting the need for a coordinated national response. The 2016 Lancet Ending Preventable Stillbirth series was another key driver, calling for a 20% reduction in stillbirth rates in high-income countries and identifying Australia as a country with scope for improvement. So in response, the National Health and Medical Research Council funded the Centre of Research Excellence in Stillbirth in 2017. It's based at the Mater Research Institute at the University of Queensland and led by Professors Vicky Flanady and David Elwood. It aims to reduce stillbirth and improve care for affected families. A major turning point was the 2018 Senate Select Committee on Stillbirth Research and Education. This inquiry amplified the voices of bereaved families and clinicians and recommended a national target of reducing stillbirth by 20% alongside a coordinated education and awareness strategy. These efforts culminated in the development of the National Stillbirth Action and Implementation Plan, which set out a coordinated national approach to stillbirth prevention across Australia. And the Safer Baby Bundle is a central component of that plan, translating evidence into that practical system-wide change. The bundle itself was developed by the Stillbirth CRE in collaboration with various health departments and clinical leaders and was officially launched in 2019. And it was informed by the UK's Saving Babies' Lives Care Bundle with some modifications for the Australian context and has achieved meaningful reductions in stillbirth.
And since the implementation, Penny, what would you say the targets of the bundle have been?
So the bundle aims to reduce the late gestation stillbirths, so that's stillbirths in women over 28 weeks gestation, by 20%. And that target aligns with the broader goals of the National Stillbirth Action and Implementation Plan. International data suggests that target is really achievable. 20 to 30% of late gestation stillbirths could be reduced. So that translates to approximately 150 stillbirths a year in Australia.
And since the implementation of the bundle, and if you think about the components of the bundle itself, what were the components, Penny?
Yes. The first component is smoking cessation, and this is a personal favourite. If you obviously for most of us, if you asked us what one thing could we do to improve outcomes in maternity in Australia, it would be smoking cessation. And I think we're all aware of that. Unfortunately, that means that smoking cessation is sometimes something that we take a bit for granted. So we had a smoking cessation clinical conversation at Sophie Care Victoria, and I'm sorry to say it wasn't one of the highest attended ones. I think because most of our clinicians think they know it and, they think, I don't have to go over that again. But there's still lots of information in the bundle and lots of steps that I think people are not doing. So it's based on the Ask, Advise, Help framework and, of course, referring women to Quitline. And we know that women who are referred to Quitline have a much higher rate of actually smoking cessation. And there are some new areas coming out like iSister Quit, which was a research tool, but I think is being rolled out nationally for First Nations women. So there is more to know about in this area, and I really encourage people to not just gloss over the smoking cessation component. It is a critical part. Early detection of fetal growth restriction and standardising an appropriate action when fetal growth restriction is detected. So this includes a risk assessment for fetal growth restriction at the start of the pregnancy, and then standardisation of the technique of symphyseal fundal height, plotting it on growth charts, and the visual aid of the growth charts can be very helpful. The whole point about the symphyseal fundal height is that it's about looking at the trajectory. The key people who should be identified are those where your first measurement is under the 10th centile, and the rest of it is about slowing growth and static growth. It's not about a single measurement. Decreased fetal movements. So this has been, I've had lots of variable feedback from clinicians about the importance of decreased fetal movements and whether we are just causing anxiety and causing more women to present. Determining decreased fetal movements, educating women about the importance of awareness of babies' movements, and giving women permission to present when they have concerns about fetal movements is a key part of the Safer Baby bundle. Side sleeping, so again, educating women not to fall asleep on their back and to aim to sleep on their side as much as they can. Reassurance in this one is important. I think when this message first came out, lots of women came in and said, oh my gosh, I woke up on my back. Have I done something terrible? So it's important that the message is don't fall asleep on your back, but if you should wake up and find that you have rolled onto your back, just go back on your side again. And finally, the last component, timing of birth. And it's been interesting marrying timing of birth from the Safer Baby bundle with that of the Preterm Birth Collaborative. They are, in fact, concordant messages. The key point about the timing of birth component of Safer Baby is where there are risk factors, the timing of birth should be chosen to allow for those risk factors. Reassessing women late in pregnancy to look at what risk factors might have developed during the pregnancy and talking about an appropriate time of birth.
So every pillar of your baby bundle is as equal to one another.
Absolutely.
Yeah.
Absolutely.
And so it has taken a few years since implementation. It's been implemented across jurisdictions now, and I'm sure you would have had many challenges in the process, many hurdles. Would you want to talk us through about the challenges that you faced?
The bundle's got very strong high-level endorsement, but implementing it on the ground is complex and involves all sorts of different systems and staff members. We do have some research from Dr Christine Andrews, who is an implementation science researcher from Stillbirth CRE, and she looked at sites that did well with the Safer Baby bundle and sites that perhaps did not perform so well. And her learnings were that the sites that did well trained through the National e-learning package, focused on collaboration rather than leaders just saying you must do this. It was important for staff to own the components of the bundle and get engagement of stakeholders, and especially obstetricians, I'd have to say, was key about having the bundle really work. Access to data is also critical. So for most improvement science and for implementation of most improvement programs, it is key that staff can audit their outcomes easily, that they can get the process measures out of their systems, and then they can look as an iterative process about how well they're doing, giving that feedback to the teams. Some of the barriers and the common challenges: insufficient resources. And I'm sorry to say that quality improvement takes time and resources, all sorts of quality improvement programs. Implementing big improvement programs without really considering the resources and the time that staff require is probably not ideal. Safer Baby Bundle initially was introduced during COVID, as it turned out, and obviously that added some extra challenges. Some of the challenges faced included the problem of data. So paper-based systems made it very hard. Audit was required, was manual, and obviously then it was more difficult for services to work out really how they were doing. In the Victorian implementation, Safer Care Victoria and the Institute for Healthcare Improvement, IHI, partnered with the health services and consumers to deliver the Safer Baby Collaborative. It was an IHI breakthrough series kind of model, and it offered a structured and iterative way to support the implementation. It included maternity services being brought together to share experiences and learnings, and that was a really popular component of the bundle. That peer learning component also helped other services address their challenges as they went through. Subsequently, Safer Care Victoria offered some new implementations of the Safer Baby Bundle in a slightly different way. So as part of our improvement program, we worked on trying to scale and spread. We used an adaptive breakthrough series collaborative model modified to have a kind of lighter touch. So the adaptations that we had were introduced in response to the comments about how intensive the original implementation was. So we tried to scale down some of our implementation components while still keeping the benefits. So we had learning sessions that were replaced with group coaching calls. So we had the whole group together, and we hopefully got that benefit of the shared learning while still having teaching components. And we had a somewhat reduced action timeframe to implement. We had milestone calls that were incorporated into the group coaching and also into the shared learning forum. We delivered it over a short period of time. There were 2 pilot phases. They went for about 6 months, so starting in August and September and finishing in February. We're pleased to say that they were really well received. We certainly improved process measures as a result of that lighter touch implementation. Obviously, stillbirth as an outcome takes a long time to gather the data to really see improvement, though.
That's a lot of layers and layers of hurdles and challenges, but you have got through and achieved what you all wanted to achieve.
Attending a regional symposium is really important for rural and regional doctors. It's a great opportunity for GP obstetricians and specialist obstetrician gynecologists to come and network, have conversations and attend a conference that is specific to the issues for rural health.
Coming back to you, Keith, you were one of the leading authors in the study examining the impacts of Safer Baby Bundle, especially in Victoria, and it's published in ANZJOG. What would you say the key findings are?
So our ANZJOG series includes 3 papers evaluating the early impact of the bundle in Victoria. I would also like to acknowledge Associate Professor Miranda Davies-Tuck, who is the senior author on these papers and also a very wonderful personal mentor to me. Paper 1 presents a population-based cohort study analysing just over 500,000 singleton births at 28 weeks or more gestation between 2014 and 2020. So outcomes were compared between hospitals that were implementing the bundle and those that were not at the time. Some of the key findings were that perinatal mortality reduced by 20% at bundle sites, with a decreasing trend in stillbirth as well, and while these outcomes remained largely unchanged in non-bundle sites. And there was a clear evidence of some clinical practice change related to each of those bundle elements, with improvements in smoking cessation and maternal reporting of decreased fetal movement and reduced rates of undetected severe fetal growth restriction. On the flip side, we know that population-level interventions to reduce stillbirth can have inadvertent harm. So we had some specific balance measures that we were measuring as well. And so it was very reassuring to see that there was no significant increases in caesarean section rates, inductions of labour, late preterm birth, or NICU admissions attributable to the bundle. And this is in contrast to the UK's similar stillbirth bundle, which did achieve a reduction in stillbirth, but had an associated increase in caesarean sections, inductions, preterm births, and NICU admissions. Importantly as well for the Safer Baby Bundle, the trends of early-term iatrogenic birth between 37 and 38 weeks declined following implementation. So these are the births that are inductions or planned Caesars at early-term gestation. And we know now that early-term gestation is associated with adverse neurodevelopmental outcomes, and reducing early-term birth is one of the key factors of the Australian Preterm Birth Prevention Alliance. So it's very reassuring to see that finding that we didn't increase those rates. While the first paper looked at the perinatal mortality on the whole, the second paper looked at the underlying causes of those changes. So using the PSAN's perinatal mortality classification system, we looked at the specific causes of death and how they were impacted by the bundle. So we found certain reductions in specific causes of stillbirth. Unexplained stillbirth decreased by about 47% from 0.86 to 0.45 per thousand births. And stillbirths due to specific perinatal conditions decreased as well by 70% from 0.26 to 0.08. And this includes things like fetal maternal hemorrhage and umbilical cord complications, true knots of the umbilical cord, etc. So there was, importantly as well, there was no increase in any category or cause of neonatal death, again providing some reassurance that these preventative efforts were not leading to any inadvertent harms. And we think these improvements were likely driven by the core components of the bundle, so specifically the enhanced detection and management of fetal growth restriction and improved recognition and response to decreased fetal movements. Many deaths previously classified as unexplained or attributable to specific perinatal conditions can sometimes reflect undetected placental insufficiency. And so by standardizing that risk assessment and detection of growth restriction and encouraging reporting of any maternal concerns for fetal movements, we think the bundle hopefully helps with this early identification and intervention. Again, on the other side, the hospitals that did not implement the bundle at the time had certain worsening outcomes in certain stillbirth causes. So stillbirths attributable to placental dysfunction increased by about 80%, and those that were due to antepartum hemorrhage, specifically driven by placental abruption, approximately doubled. So again, showing that possibly protective effect of the bundle. And finally, we really wanted to have an equity lens to our analysis. And so we looked at the outcomes in demographics that we know are disproportionately impacted by stillbirth. And so the third paper looks at shows that the benefits were not experienced equally, and with significant gaps identified for migrant and Indigenous populations. Really shifting the focus from a universal standardized implementation to one that is culturally safe and tailored for the group. So there was a limited impact among the migrant populations, and stillbirths remained largely unchanged for women that were born in Africa, South Asia, and the Middle East. Among Indigenous women in our cohort, stillbirth rates actually increased. The numbers are very small in this particular cohort in that particular time, but it still raises some concerns that the standard bundle probably wasn't effective for that particular cultural group. And so the bundle, I think, should be seen as an evolving framework over time and really needs to be co-designed with communities. And initiatives by the Stillbirth CRE, such as Stronger Bubba-Born and Growing a Healthy Baby, which are cultural adaptations of the bundle, which we'll get into a bit later, offer a model of that culturally safe approach.
So it's fair to say that our bundle is an inspiration for others in the world to give positive outcome as well as to reduce the negative collateral changes that others have seen.
Yes, exactly.
Yeah. Okay.
Absolutely. My use of symphyseal fundal height measurement has completely been changed by these programs. And I'd have to say I've had a bit of skepticism expressed by various colleagues about the effectiveness of symphyseal fundal height. And, ideally, of course, I'd love for every woman to have fortnightly growth scans throughout her entire pregnancy, but clearly we cannot provide that sort of service anywhere. So symphyseal fundal height is a cheap tool and easy to use. And I think the fundamental problem for the clinicians who express that skepticism is that they haven't seen it working properly. So to really use it, you actually need to credential your staff on how to do it, and it needs to be done in a standardised fashion. And also, staff need to know exactly what to do when they do notice changes in symphyseal fundal height, so slow growth. How do they manage that? Again, that next step has to be done in a standardised way for it all to be effective. And it's been really interesting working with the bundle and finding out what are the different practices that people are doing, discovering that maybe one of your staff members actually just feels for the tummy and says, oh, that feels like a small baby, rather than actually measuring the height in a standardised way. So, it's certainly changed my practice.
So a simple, quantifiable practice that can make a difference.
Absolutely. And standardised between different people as much as possible.
And coming back to stronger baba, born and growing a healthy baby as cultural adaptations of this bundle, what makes these approaches effective, and what should clinicians do to integrate this in their day-to-day clinical practice?
So as we've touched on, our research exposed a critical equity gap in the bundle. But even prior to this research, actually, the Stillbirth CRE already recognised the need for culturally tailored resources and were already leading the development of 2 major cultural adaptations. So Stronger Baba Born was co-designed with and for Indigenous women and led by an amazing team of researchers, First Nations researchers within the Stillbirth CRE. And I want to acknowledge Deanna Stewart-Butler, Valerie Archie and Sky Stewart, to name a few. And Growing a Healthy Baby was, again, co-designed with and for migrant and refugee women. And again, Associate Professor Miranda Davies-Tuck was leading that package of work. First, focusing on Stronger Baba Born, we know that Australian, Aboriginal and Torres Strait Islander women experience stillbirth rates that are double that of their non-Indigenous counterparts. And standardised checklist-driven care can often fall short because it really doesn't account for that institutional racism, intergenerational trauma, or any of the First Nations health perspectives, which can emphasise that which often emphasise connection to country and community. And so the Stronger Baba Born program was developed over 2 years through extensive community collaboration and consultation, including yarning circles and interviews with community members and Indigenous healthcare workers across 18 communities in Australia. The resources use a strength-based approach. So Stronger Baba Born reflects a baby born healthy and strong, and Sorry Business Babies is used as the culturally appropriate term for stillbirths. A key component is the Healthy Yarning Guide for clinicians, which supports that two-way learning and relationship-based care. And this really shifts away from that transactional model such as the ask advice and help, and instead really prioritizes that trust and connection. Then looking at Growing a Healthy Baby, again, we know that stillbirth rates are higher in some migrant populations compared to Australian-born women, particularly those from Central and Western Africa and South Asia. Language barriers, stigma, and limited access to culturally relevant resources really contributes to this disparity. And while the standard Safer Baby Bundle resources are already translated into more than 30 languages, Growing a Healthy Baby is a culturally adapted bundle for the Arabic, Dari, Dinka, and Karen communities. This involved collaboration with community groups such as the Multicultural Centre for Women's Health, as well as the Stronger Futures CRE, to really ensure that the content and the illustrations were culturally appropriate and reflected the population we were trying to achieve. One important gap addressed is the alternative use of tobacco use in this population. The standard bundle focuses mainly on cigarette smoking, but in some countries, water pipes and smokeless tobacco are more common, as well as passive smoking within the household. And so these forms of tobacco are explicitly addressed in these adapted resources. On top of this, some cultural groups actually don't have a translated word for placenta. And so bringing emphasis on placental dysfunction and placental health is extremely difficult when we don't have that vocabulary to expand on that topic. Hence the analogy of growing a healthy baby as like growing a plant or growing a particular body of life was synonymous with that placenta to try and really bring that education to a cultural lens. And so this really essentially improves accessibility across different literacy levels and delivered across multiple formats, so animation videos, audio resources, and written booklets. And essentially these adapted resources have addressed three key barriers. They really prioritize trust amongst the cultural groups with culturally safe language and approaches. They promote that linguistic accessibility, so ensuring those key clinical messages are understood and accessible, and they enable that context-responsive care. So by responding to and recognizing the influence of the family and the household and the cultural practices around them.
Very interesting perspective of language and culture barriers. So, Keith, like you said, this bundle would be an evolving, and I think it should be evolving as new challenges come across your way in the future. If you think of areas that you can change and think into further research into the bundle and its implementation, what areas would that be?
Well, several areas, I think, where future research is needed. Firstly, I think really the equity and cultural adaptation. So obviously the initiatives like the Stronger Bubba Born and Growing Healthy Baby are so promising, but we need robust evaluation of the impact on those outcomes. So it's not enough to develop culturally tailored resources. We need to understand whether they're improving engagement, changing care, and ultimately reducing stillbirth in these populations. Secondly, I think national level implementation and evaluation is super key. The ongoing national evaluation of the bundle, again led by Dr. Christine Andrews at the Stillbirth CRE, will be very critical to understand how the bundle is being developed and delivered across different jurisdictions, and what level of implementation is required to achieve that meaningful impact. And finally, there are a whole heap of broader research priorities in stillbirth prevention. So placental dysfunction still remains a leading contributor, and there's quite strong interest in improving that early detection through novel biomarkers and more precise risk stratification. And there's also a really growing potential for integrating artificial intelligence into stillbirth prevention, particularly in areas like fetal growth restriction, risk prediction, and clinical decision support. So the next phase, I think, is not just about implementation, but really refining how we deliver care and improving the tools that we use to identify risk earlier and more accurately.
And like Penny, you said, it's bottom line is clinicians who need to change for any implementation to take off and work and go through all the challenges. For all the clinicians out there, what do you think are the resources that they have if they want to improve the bundle in their own clinical practice?
So Stillbirth CRE have a number of resources which are great on their site. They've got e-learning courses covering the Safer Baby bundle and courses focusing on the culturally adapted bundle. So there's the Stronger Bubba Born Healthy Yarning Guide and partnering with families of refugee and migrant backgrounds. And I'm sure that sounds like there's going to be work on a lot more guides coming. There are dedicated courses to support maternity healthcare professionals in caring for women and families following stillbirth, as well as a professional development program for interpreters working in that particular bereavement area of pregnancy care. They also have a Caring for the Carer course, which provides trauma-informed strategies to help clinicians sustain their own well-being. There's a whole lot more resources, which are all under the resources tab at the Stillbirth CRE website. In regard to adapting the bundle locally, we expect people to use improvement science, I guess, to do local adaptations. So PDSA cycles and particularly partnering with consumers would be key for that.
And to all the clinicians who are listening to us, and what would be the key messages from the two of you to do and implement and carry on with this bundle?
So I think, three key takeaways for clinicians. I think, firstly, the fundamentals matter. So consistent attention to fetal growth, timely response to decreased fetal movement, smoking cessation, sleep position, and really thoughtful decision-making around timing of birth can make a real difference. The bundle is not really adding much complexity to what we already do, but making sure that we do the basics well every time. Secondly, I think implementation matters. So the bundle is most effective when it is applied consistently and supported by systems, including education, clear pathways, and access to data. And small gaps in practice can have that significant consequence. And finally, again, equity needs to be front of mind. So a standardized approach will not work equally well for all populations, and clinicians need to engage in that culturally safe care and culturally safe resources, build trust with their patients, and be responsive to the individual and community needs if we want to see those meaningful reductions in stillbirth across the whole population.
So I've been a clinical leader in implementation of the Safer Baby Bundle in 3 different health services. And I've also had involvement in implementation in the Learning Health Network through Safer Care Victoria. If I could speak a bit more broadly for a moment, my experience has shown me that all improvement work takes time and resources, so it's critical to allocate that. We found that improvement work was more effective when there was good buy-in from executive. So although we don't like to talk about top-down, we want the clinicians on the ground to own and really be interested in it. It also helps if you have strong support and driving from the executive level, particularly because they are the ones who control the resources, really. Broadly, my experience has shown me that the results are a significant uplift in implementation and understanding of improvement processes generally when clinicians take part in these improvement programs. We find that when people take part in the projects, that knowledge and that understanding of the process extends to other areas, and we hope that eventually, leads to more uplift in all sorts of different areas of care.
Thank you so much, both of you, for sharing your experience in the Safer Baby Bundle. And genuinely, we have made a shift of 20% reduction in perinatal mortality, which is evident locally, nationally, and internationally, I would say. And again, like you both said, it's very important about implementation and not forgetting equity at any point in any of the implementations that we have. And rightly said, Penny, yes, the evidence, the resources, everything's out there for all the clinicians who are watching us, and it's us who need to do what we need to do in order to improve the outcomes. Thank you so much. You can find the resources discussed in today's episode via the link in the show notes. If you enjoyed this episode, please rate, review, and subscribe and share. And don't forget, RANZCOG members can log CPD hours using the form attached in today's show notes. We'll be back soon with more conversations on Talking O&G.